So my second case, it's a 41-year-old male who was diagnosed with 10 years back as chronic phase CML in January 2013. He was started on 400 mg of imatinib. After 2 months of treatment, in view of severe thrombocytopenia, the treatment was stopped for 2 months and restarted. The same like the previous case, there was cytopenias. So he got evaluation with bone marrow in November 2013, which showed complete cytogenetic response and was continued on imatinib 400 mg in July 2014, March 2015, and July 2016. So a 3-year time period after the restart of the imatinib, the BCR-ABL was 0%. He was in complete molecular response. But in November 2017, the BCR-ABL started increasing 3.79%, but the patient is not willing for any further workup. We thought, so we'll repeat it after some time and see and decide on what to do. And we counseled the patient to get it done after 8 weeks, but the patient got the test done after 6 months, which was 0.899%. So in March 2018, again, it was 0.009, and he was continued on the imatinib 400 mg. So in 2022, after 4 years, the BCRA will again start increasing. It was 2.08%, and the kinase mutant domain mutation testing, which was done, which showed dual mutations M244V and T315 mutations. So after approximately 9 years of treatment, so the patient developed T315I mutations, and he was counseled for the need of allogenic stem cell transplantation because ponatinib was not available with us. And in August 2022, so under the Compassionate Access Program, we are able to get the asciminib, and we started the patient on 200 mg of twice daily. So in view of the thrombocytopenia, the dose was decreased to 160 mg and was continued on it. So this is the second case. So over a period of time, so we have not used much of TKIs. We used only imatinib. So there was only a short interruption of treatment for 2 months. Otherwise, he had a good compliance. But the BCRA will continue. He had a response for a period of 6 years, and slowly the BCRA will started increasing. And all of a sudden, the patient developed a very severe resistant mutation like T315. But the patient has complete hematological response with asciminib, and he was an asciminib for a period of almost 9 months till now. So in this scenario, so how best we can manage this case further? And is continuing asciminib is better, or we need to proceed for allogeneic stem cell transplantation because he has got a good response to asciminib? And if we do an allogeneic stem cell transplant in this patient, does this patient need a TKI maintenance post-transplant? So if at all needed, so what will be the ideal TKI post-transplant?
I think it's a little unusual to have like relapses like this, but they certainly happen. A question, of course, would have been whether there were changes in compliance when the BCR-ABL went up. It was appropriate not to react to a single transcript value, that 3.79%, and to repeat it. And in fact, it improved over time, maybe suggesting that there was a lapse in therapy. At the time in April, when the BCR-ABL was 2%, suggesting a loss of a cytogenetic response, we would have done a bone marrow looking at blast percentage, and certainly would have done the kinase mutations as you did. Then the question here would have been whether to use asciminib or whether to use ponatinib. That's an unanswered question. They are the choice for patients with a T315I, and we don't have enough long-term data on asciminib, but we know that you can have very good responses with the T315I. What we forget is that the dose of asciminib for T315I is much higher, and the cost is absolutely outrageous. It costs like 3 transplants or something like that. It's an obscenity how that drug has been priced. But in any event, you got it. And the question is it working? clearly there's a high probability that this person will need an allogeneic transplant, but there are people on long-term TKIs or asciminib who have, with the T315I, who can have an excellent long-term response without transplant. And what I think I would do in this case is to monitor this patient very frequently, let's say every 2 months, for example, with PCARs, and in the meantime, make sure that everything is arranged for a transplant so that if the drug stops working, this person can go to transplant expeditiously.
So I would agree with all that. I think I would also add that I think in this patient, I would probably be doing a bone marrow, assuming they were maintaining their response, I would probably do a bone marrow at least annually, just to make sure there were no additional changes within the bone marrow that were being missed on the peripheral blood monitoring. Obviously, the transplant comes with a significant morbidity and mortality. So in the shorter term, I would say continuing the asciminib, but the longer the patient stays on asciminib, if they do then progress, the worse the outcome for transplant is likely to be as their risk scores increase and potentially they acquire more comorbidities as they get older. So I think it's a really difficult balance. And then in terms of the final question about TKI maintenance post-transplant, I think the answer is probably, if this patient did go to transplant, I think the answer is probably yes, but then it comes down to whether or not the patient is going to tolerate the asciminib. I very much doubt they would tolerate the dose that they're on just now post-transplant. So you may be looking at giving them a chronic phase dose just because of the cytopenias post-transplant risks of other complications like GVHD or CMV reactivation. I have one patient who has been in this position who actually had blast phase with a T315I mutation who went to transplant, and they were on ponatinib, not asciminib though, and 3 years post-transplant they're now on 15 milligrams of ponatinib post-transplant. We're probably planning to keep that going for a few more years at least, I think, and they're having their BCR-ABL monitored every 3 months.
Stalin, how do you feel about that? Do you think your questions have been addressed there? Maybe Hemant, do you have a quick comment and then we'll move on?
Yeah, okay. I have 2-3 comments, but I'll be very quick. Number one is that as Dr. Charles Schiffer pointed out, I think the clinicians should not respond to one BCR-ABL report because it's a tricky test to do, and every lab once in a while goofs up. So you must repeat the test after 1 or 2 months, and if there is a similar trend, then only you should react to that. And number 2, I think non-compliance is the number 1 cause of the TKI not working, or a suboptimal response, or a loss of response. So that must be ensured. And number 3, that we don't call a 0 PCR level complete molecular response anymore. We just call it a deep molecular response. And my final comment is that, asciminib is going to be available in India in maybe end of this year or the first quarter of next year. And then the compassionate access for this particular patient will stop as per the contract they signed with us. So it might be a good idea to start planning for transplant for this patient, because asciminib, when it comes to India, it's going to be horrendously expensive.